today is the second and third phase of urine formation. First process was filtration, and today we will be discussing about tubular reabsorption and the secretion, tubular secretions. Okay, and here are the questions from this today's lecture. What are these? Actual renal threshold is explanatory question. Actual renal threshold of glucose is less than the predicted value. And the other questions describe the mechanism of water reabsorption, water not absorption, water reabsorption in the different segments of renal tubule, glucose reabsorption in the renal tubule. Okay, and so there will be one correction. It is reabsorption. I told you on it is different from absorption. Why? These substances were mine. Once it was mine. Okay, it was going out. So that's why I am reabsorbing it. Absorption, it happens in GI tract. In intestine, absorption happens. It was never before. It's a new thing coming into my GI tract. So that I am absorbing. It was not before in me. Okay, so that's why it is reabsorption and the other one is absorption. Okay, so our objective is general principles of renal tubular transport. Transport means reabsorption. Transport across the different segments of renal tubule. Renal handling of common solutes, particularly I'll try, but I'm afraid I will be not be able to complete all those solutes. I'll try to explain the sodium reabsorption, water reabsorption, bicarbonate reabsorption. Okay, so these are the main, and glucose amino acids. If you know how glucose is absorbed, then you will be knowing amino acids and other compounds, how these are mechanism is same. And renal handling of common solutes, that's the thing I told. Renal threshold and transport. This is also important thing. It will be frequently utilized. TM stands for transport maxima and renal threshold of glucose of different substances. And what is tubular reabsorption? Tubular reabsorption in the kidneys is the process by which water and essential solutes filtered from the glomerular capillaries are transported back into the bloodstream to maintain homeostasis. This process primarily occurs in the proximal tubule, but also takes place throughout the entire length of the renal tubule, including the collecting ducts. It regulates blood volume, electrolyte balance. It controls pH balance and means acid-base balance. Okay, returns valuable substances like glucose, amino acids, and salts to the circulation, including water. And the general principle is renal tubular transport. Transport happens in two ways. In between the epithelial cells, there is junction. Tight junctions are there. Some substances will be passing through the tight junction into the capillaries from the lumen. So this is called paracellular transport. In between the cells there is a gap, but guarded by fixed by tight junctions. But some solutes they can pass through these tight junctions. So from the lumen through the paracellular transport, this is called paracellular transport. So paracellular space, then it will enter into the interstitium, then into the capillaries. So this is the route. After reabsorption, where it will go? First it will enter into the interstitium, then in blood. Okay? And transport across different segments. We will see the maximum transportation is made. Transportation means absorption is done in proximal convoluted tubule, also in other parts also reabsorption takes place in addition to secretion. Okay, tubular transport of common solutes and water. These are, what are these? Sodium, chloride, potassium, bicarbonate ion, glucose, amino acids, water. These are the things actually transported. Okay. And mechanism, these are two mechanisms are involved. One is passive, another is active, mainly active transport. Okay. And two hormones basically controls this reabsorption process. One is aldosterone. Aldosterone is concerned with sodium as well as it actually controls, aldosterone controls sodium reabsorption. And sodium doesn't absorb alone. It takes water also along with it. So it is would be the passive. Water absorption is because of the sodium. Since sodium cannot go alone, it will take hydrogen or water along with it. Okay. And there is ADS. It will cause only water reabsorption. Okay, from the renal tubule. And this reabsorption mechanism is important for this purpose. What is the importance? Vital for maintaining the blood volume, electrolyte balance, preventing the loss of essential nutrients like glucose, amino acids, sodium, these are the things. Okay, and the see, this is peritative tubular capillaries, blood capillaries, from where this will be absorbed. This is the interstitium. Okay, this is the lumen. Okay, the lumen of the renal tubule. So from here, the solutes enter through paracellular path or transcellular path. So transcellular path is the main bulk of the nutrient solvents pass through this transcellular path. And water can pass transcellular way as well as through paracellular way. And solutes are transferred by active and passive transport. Okay, so these are the mechanisms that will be involved. Okay, now let's see what a lot of things are filtered. Whether everything will be absorbed. So we can see nothing will be reabsorbed. Everything will pass through the urine. There are some solutes. All will be, for example, creatinine. This will not be reabsorbed. Everything will pass. Okay. Here, another substance. These are filtered, but part of this reabsorbed. And rest part is passed through the urine. For example, sodium. 99% is reabsorbed, 1% is secreted through urine. And another substance which are not at all excreted, these are filtered, not at all secreted, not at all, you will not get it in urine. And these are because all of this will be absorbed into the peritubular capillaries through renal epithelium. What are these? Can you tell them? These are filtered, but not present in urine. Glucose. If you test urine, you will not be having glucosuria. Blood glucose, amino acids, these are filtered. So all these glucose under normal condition, if you don't have diabetes, okay, then all the glucose will be reabsorbed. So this is the example, substance Z. Okay, amino acids are the example. Sodium you can say, because 99% is reabsorbed. Transport across the different segments of the renal tubule and across proximal tubule. See, proximal tubule is very important. 67% of the water, sodium chloride, potassium, these are glucose, amino acids, all are absorbed in the proximal tubule. Rest part is reabsorbed or secreted from the rest part of the renal tubule. So proximal tubule is very vital to us. Whatever filtered, from that inulin, creatinine, sucrose, mannitol, these will never be reabsorbed. These will be secreted. Okay, reabsorption some important substances. So I will be starting with glucose. Okay, how glucose is reabsorbed? This is completely reabsorbed. Glucose will be completely reabsorbed from which part? Proximal part. And when the filtrate pass from the proximal part to the loop of Henle, no glucose, no amino acids you will get. So all of these will be absorbed in the proximal tubule. Okay, in the proximal tubule, there are some transporters for glucose. The proximal tubule you can divide into early part and the late part. Okay, so initial part, late part. So in the initial, we'll see the difference. In the initial part, which receptors are there? Glucose receptors. Which glucose? We know GLUT receptor, not SGLT. There is one, SGLT2. See where they are present. Reabsorption of glucose. An overview, what is this? Glucose is freely filtered at the glomerulus, no problem in filtering because their size is very small, smaller than the pore sizes, and they are not negatively charged, so they can easily filter. Okay. Next is glucose is freely filtered at the glomerulus under normal physiological condition. 100% of the filtered glucose is reabsorbed in proximal convoluted tubule. Okay, you all always try to remember this. And no glucose should appear in urine unless the renal threshold is exceeded. Our renal threshold is 180 milli when blood or in the plasma of venous blood or arterial blood is 180 milligram %. If it goes beyond that, then its capacity is up to 180 milligram %. It can absorb, but beyond that, glucose cannot be absorbed. This will come into urine. So whenever this threshold will be exceeding and glucose will start to appear in the urine, so there will be glucosuria, means there is definitely hyperglycemia. And what is the cause of hyperglycemia? You have to identify. You have to then, okay, whenever you are finding there is glucosuria, there is a chance of having diabetes in the patient. So you will perform some tests. What are the tests? One is oral glucose tolerance test. Okay. Another is HbA1c. It should be more than 6.5%, and glucose tolerance test value should be more than 200. Random sugar should be more than 200. So these are the tests by which you can confirm. That too. Initially you got this thing, except HbA1c, you got high value of all other things, but the patient may not have diabetes. So you have to manage the patient with dietary management. You have to manage with dietary. You have to curtail the diet, different things you have to curtail. Then you have to try to manage the dietary procedure. And if this thing happens in 2 different occasions, then you are sure that he is having diabetes. Then you can start the management, pharmacological management. Okay. Now, where from, as I said, the glucose is transported back from the proximal convoluted tubule. So here you will find that the cells, these are the epithelial cells. Epithelial cells. This is paracellular space, and this is the cell, transcellular transport. So here, this is the lumen of the renal tubule, and here is the interstitium, and here lies the capillaries. Okay, here lies the capillaries, peritubular capillaries. So, from this lumen, they will be entering it either in two ways. There are two paths. One is through the cell, another is in between the cell. So, they will be entering into the interstitial space, then they will be entering in the blood capillaries or peritubular capillaries. Okay, so this is the path. Okay, so in this proximal tubule, we have for transportation in the early part of proximal convoluted tubule, that is S1 segment of the proximal early part, initial part, they are having SGLT2. These are having SGLT2, glucose transporter, okay, receptor. And the later part, that is S3 segment, they are having SGLT1. We'll see the functional difference. And co-transport driven by sodium gradient maintained by sodium potassium ATPase pump means what? This is the cell. Here are the transporter SGLT2, okay, and this is the lumen and this is the interstitial space, and here are sodium potassium pump, particularly in the basolateral region. This is the basolateral region. In the region, what is there? Sodium potassium pump. So through this pump, sodium is pumped out into the interstitium, and in addition, potassium is from the interstitium, and where from it is coming? Coming from blood. So this potassium entering into the cell through this pump. Here ATP will be involved. Okay. Now what will be there? There will be within the cell concentration of sodium will be less because it is pumping out. So there will be less sodium ion for a sodium ion. As a result, within the lumen there are a lot of sodium ion. So there will be a gradient. This sodium has gone out. No, in the cell there is less sodium ion, but here is more sodium ion. So sodium ion try to diffuse through a transporter. What is this transporter? SGLT2. And in addition, they will also glucose will be transported at the same time. Co-transporter means it is because of sodium entry. This is created. Why it is created entry? Because the negativity inside, low pressure of sodium. And when sodium is coming in, for a glucose said, I will also go with you. The energy, normally I cannot go, but you have lot of energy. This difference, gradient, so I will go enter with you. Okay, come. So, through this pump, through this co-transporter, along with sodium, glucose is transported within the cell. And from this, another transporter is there. What is the GLUT? It is the GLUT transporter. So from here, this glucose will be coming into the interstitium, then it will enter into the blood capillaries. Okay. SGLT is present in the later part of the proximal convoluted tube. Here, instead of SGLT 2, it will be 1. And along with sodium will also enter for the same reason. But here one thing is, instead of 1 sodium, it will carry 2 sodium. That one can carry 1 sodium. Here it can carry 2 sodium ions. Okay, this part is same. So, why this glucose is entering? Not by its own force. Somebody is helping its entry. Who is helping? Sodium. How he got the energy? Because sodium potassium pump at the basolateral region, it has pumped out the sodium that were present within the cell. As a result, the pressure or concentration of sodium became low, where in the lumen it is high because of this gradient sodium is entering. through the transporter. So the transporter will not carry only sodium, that it will, along with it will carry glucose. This is the mechanism. Okay. Basal membrane. There is facility, it is facilitated by this sort of absorption, facilitated by sodium absorption. Okay. Now see, any problem in understanding this? Follow this. SGLT1, for one glucose molecule, it is sending 2 molecules of sodium into this, whereas here 1, SGLT1. And 97% of glucose is absorbed by this, and only 3% its contribution is very less. So if you want to control diabetes, so you have to choose some drug that will block this one. If you can block this one, the sodium will not be absorbed back into your blood, that will be excreted through the filtrate. Okay, there are many drugs that are developed for blocking this transporter. Same thing. Now I made one comparison between SGLT1 and SGLT2. See, location where they are located, S3 segment or proximal tubule SGLT1 and SGLT2 where these are located in S1 segment. Okay, and substrate glucose or galactose, and it is only specific for glucose, and extrarenal localization, it is present in GIT, also in RBC, and liver they are present. Affinity for glucose, its affinity is very high in SGLT, but low. Though low, but its efficacy is much more. SGLT I told, so that's why it can transport 97% of glucose because of this increased capacity. And their capacity of transporting glucose is less relatively. Okay, and percentage, I will say 10% and 90%. And clinical syndrome, because of this, there may be diarrhea, and because of the inefficiency of this, there may be glucosuria. Now, transport makes sense. These two concepts must be clear to you. What is this? One is renal threshold and one is transport maximum. What is transport maximum? The maximum reabsorption capacity of glucose is 375 gram per minute. Okay, not per ml. Okay, it is their rate. Transport rate. Okay, gram per minute. Whereas renal threshold is the plasma glucose level. What is the unit? Plasma glucose level, milligram per 100 ml. Okay, both of these are different. So there is a threshold condition. Means, okay, see, all glucose are filtered. Now, proximal tubule, it has to reabsorb through the receptors, through the SGLTs. Okay, and some enzymes are there, so they must be sufficient in, but their number of receptors, enzymes, amount of enzymes is not unlimited. So there is limited. So because of this, lot of students are waiting in the platform for train, and one train came having 7 to 8 compartments. But here students are thousands of students. All can be accommodated in the train? No. Rest will be waiting in the same thing, since compartment means enzymes and the receptors. Their amount is limited. that's the blood glucose amount that are transferring. If it exceeds beyond its capacity, only according to the seat capacity of the compartment, they can carry. Beyond this capacity, they will not be carried. They will be retained in the urine. They will be passed away through the urine. Means there will be glucosuria. What is the capacity of the three bogies? That is likewise. There will be a capacity of these epithelial cells, limited amount of enzymes, and because why? You may ask question. You see why it is 180 milligram percent blood glucose, when blood glucose level is 180 milligram, goes beyond 180, why it is not possible to reabsorb all the, why? Because we are not having sufficient enough number of receptors as well as the enzyme, those who will be transporting it. Because of the deficiency, not deficiency, their limited amount. So that is the transport maximum. Okay. So plasma glucose level at which glucose first appears in urine, that is called renal threshold. So when it exceeds, there may be glucosuria. It can be explained through a diagram. Go through it. Go through the lines. This is important. Clear concept you must have. And I will advise you to go through the book of the Guyton. It is clearly, nicely written there with graphical representation. So this graph you will get there. And question is come, in this relationship, what is the relationship? The graph explains relationship of plasma glucose level. This is the plasma glucose level, and this is the glucose filter load of the glucose in the filtrate. Load of how much glucose is passed into, means gram per milligram per minute. What is the rate? Loading. Load. What is the load? So this is the load and this is their relationship is explained. Okay. If you go on increasing the glucose concentration, and it is rate of glucose load, glucose filtration will automatically increase, linearly increase. But when, according to this, it is the 375. This is the TM is for glucose is 375 milligram per minute. How much? TM for glucose 375 milligram per minute. Okay, it is that level. Okay, so during this time 375, what is the plasma glucose level? Nearly 400. But you can see much before glucose is start appearing in the urine. Okay, so this level 180 or 200 is the renal threshold for glucose. And this area, it is called the splay. So what is splay? In the relationship of this and this, explain. Okay. So for that purpose, I tell you, consult the Guyton book. Okay. So glucose absorption is over. Now I will explain the sodium reabsorption. Very important. Very important sodium. Because if we lose sodium, then it will be very difficult for us to maintain blood osmolarity, extracellular fluid osmolarity, blood osmolarity, so everything will be damaged. And see, sodium performs many functions. One is blood pressure regulation, and the other is extracellular fluid volume. If it is altered, extracellular fluid volume may be increased in case of edema. Okay, if your sodium is retained, not excreted, then your volume will be increased. There will be hypertension. There will be that volume is increased, there will be hypertension. That's why what is given? For removal of the sodium, excess sodium, some tablets are given. So sodium load of the body tissues will be decreased, then blood pressure will come down. Okay, so it is fluid volume, also blood pressure regulation, acid-base balance also, sodium regulates. Driving, it drives, we have seen. Because of the sodium absorption, glucose is absorbed. If there is no sodium, so glucose will not be absorbed. If there is more sodium, more glucose will be absorbed. If the receptors, GLUT, SGLT are sufficient in their number, enzymes are sufficient. Okay, so that's why this is very important. So 99% of the filtered sodium is reabsorbed along the various segments of the nephron, and out of this 65 to 70% is absorbed in the filtered. What is the amount? This X amount is the filtered amount. So it is nearly 2,000, 25,000 per day we are excreting, and out of this 99% we reabsorb. Okay, 99% is reabsorbed, and out of this 65% is reabsorbed in proximal convoluted tubule. Now this is important. Various parts sodium will be reabsorbed. Okay, see, proximal convoluted tubule 65 to 70% of sodium is reabsorbed. Okay, what are the transporters? These are the transporters. With the help of these enzyme transporters, these 65 to 70% sodium is reabsorbed. And in the thick ascending limb, the thick ascending limb is passing through the JG apparatus. Okay, that limb absorbs 20 to 25% of the sodium, with which sodium potassium 2 chloride co-transporter. Okay, that too with the help of sodium potassium ATPase pump. Okay, here sodium potassium ATPase pump will also be involved. Distal convoluted tubule DCT only 5 to 7%. Distal convoluted tubule also having two parts. Before entering collecting tubule, this is the later part, late part, and just before this there is the early part. So their mode of absorption is different, two parts. There is, I will see how it differs. Okay, so in distal tubule 5 to 7% are reabsorbed, and in the collecting duct 3 to 5%. Okay, and this is secondary to water reabsorption. We know in the collecting tubule under the action of ADAs, water is absorbed. So because of this solvent pool, some sodium will be absorbed. So this is a passive process by this 3 to 5% will be absorbed, and here this is done completely by ADAs hormone. So ADAs hormone and the ADAs and what is the aldosterone? This is the contribution of the aldosterone, and this is the contribution of the ADAs mediated. Okay. Proximal convoluted tubule, how these are absorbed. What are the enzymes? What are the transporters involved? Okay, I said 65 to 70% are absorbed here. So here, sodium, hydrogen, antipode. Sodium will be absorbed from the lumen into the cell, and the cell will excrete hydrogen ion into the lumen. So there is an antipode. Okay, and it is what? Energy-based active transport. Okay, another is sodium co-transporter. Okay, sodium, by this co-transporter means these are what? Sodium solid, sodium glucose transporter, SGLT, sodium amino acid co-transporter. So they will help the absorption of sodium. Okay, and sodium potassium pump is because this pump generates. I said, from here the pump will, sodium potassium pump, they will pump out sodium and pump in potassium. So no sodium will be here because of this pump. Now what will be? There is less sodium, here is more sodium. So sodium will be entering, and along with some glucose will be, or amino acid will be entering. Okay, so this pump is actually facilitating the absorption of sodium as well as glucose. This pump. Without this pump, it is not possible. Okay, and water reabsorption. Here, the water is also reabsorbed to make the fluid isotonic to the interstitial fluid. As I said, ATP, sodium, potassium, ATPase pump. It is pulling sodium. This sodium is entering into the blood, and from here, potassium is entering here. Okay, as a result, here sodium level is reduced, ATP will be used, so there will be diffusion of sodium into this. So along with this sodium, some glucose will also be entered. Okay, moreover, see, inside the cell, outside the fluid is having -3 millivolt. Okay, but here is positively charged, there is a difference in charge. As a result, sodium will be entering into this, also through this, so that it can come to paracellular. This is paracellular path. Through this path, sodium can enter into blood. Okay, any doubt? No. And early proximal tubule, which is the lumen side, this is the lumen side. So there is SGLT2. So with the help of SGLT2, glucose is absorbed, sodium is also absorbed. Okay, sodium potassium pump, it is sodium is absorbed and this is eliminated here. What is the interstitial space? Okay, so bicarbonate ion is also sent into the interstitial fluid and sodium is reabsorbed. Okay, so here basolateral membrane sodium potassium pump will be involved. We have seen sodium potassium pump is there. Apical membrane is having sodium hydrogen antipode. Okay, sodium is needed. Hydrogen ion we don't need. So I will secrete it into filtrate, and from the filtrate I will take back sodium ion. Okay, and sodium glucose import, as I said, it is known to you. Okay, now late part of the proximal here. What is happening? This is co-transporter. Here in the late part, co-transporter is different. Here there is 3 electrolytes can enter within the epithelial cell. What are these? Sodium, potassium and 2 chloride. Okay, they can enter through this. How they will enter? Where is the energy? Created by this. They expel sodium from these cells into the interstitial, renal interstitial, means from here to blood. As a result, here sodium concentration is reduced, but outside is more. So sodium ion will enter, and through this enzyme, in return it will be excluded. And here also sodium 2 chloride and 2 potassium ion. This is called sodium potassium 2 chloride co-transporter. Okay, and this will facilitate absorption of sodium from the lumen into the cell. From this cell, the sodium will be sent back to the blood. See, as I said, like LUT, SGLT, there are separate, this kind of transporter is also there for amino acids. So amino acids, while amino acid will be entering, while sodium will be entering, they will also facilitate the entry of amino acids. Okay. Similarly, while entering the sodium, they will also bring within the cell phosphate, lactate and citrate. So they are, lactate we can metabolize. In the cardiac cell we can metabolize. They are important also. And citrate is also one of the constituents of TCA cycle. I can also utilize this. This is also important for us. That's why we will absorb it. Okay. Bicarbonate, very essential. We will try to reabsorb nitrogen. No bicarbonate ion should present within the urine. Everything happens because it will neutralize our excess acid. When we generate in our body, generate excess hydrogen, excess acid, that will be neutralized by the bicarbonate. That's why it is very important. We will try to preserve this. We will not allow its excretion. Okay. So bicarbonate ion is very essential. In the late part, those transporters are absent. Sodium, potassium, 2-chloride transporters are absent. Only what is there? Sodium, potassium. Here the side is reversed. Okay, this is the lumen side and this is the blood side. So you see these are the transporters. It is already explained. Now, sodium reabsorption in a thick ascending limb. Here also you will get sodium, potassium, ATPase pump in the basolateral membrane and sodium, hydrogen, this antipode also present in the apical membrane like before, and potassium separate potassium channels RO and K in apical side, and there is chloride channels in the basolateral region. So graphically I am showing it. So this is the graphical presentation of this. You can very easily get the points. Distal convoluted tubule, I said there are two parts. Okay, see. This is the distal convoluted tubule. And what is this? DCT part 2 and DCT part 1. Okay, so this one, what is the mechanism of sodium transport? And for this part, what is the mechanism of sodium? Can you find the difference? Here, aldosterone will not act. Here, aldosterone will act. And because of this aldosterone, sorry. Chiller difference. Aldosterone will act here only. This part. Here there is no action because aldosterone receptors are absent here. Since with the action of the aldosterone, what is this? Aldosterone causes implantation of these receptors. So because of these receptors are absent there. So because of this, lot of sodium can enter. So, okay, this is the lumen side, and this is the blood side. Okay, so here you can see the difference. And this difference is due to aldosterone. Now in the collecting segment, here everything will be done by which hormone? ADS. It will reabsorb water by implanting what? Aquaporine. Aquaporine, these are the path channels through which water will be from the renal tubule will be entering into the cell, from the cell into the interstitium, from the interstitium into the blood. Okay, so these aquaporine are actually, how many aquaporine will be there, how many aquaporine will be active, this is regulated by the hormone ADS. When there is no secretion of ADS, there will not be any functional aquaporine, so water will not be absorbed. What is this? This is a channel. C stands for channel. Na means sodium. E stands for epithelial cell. In the epithelial lining, apical epithelial lining, there are some sodium channel induced by, implanted by the action of ADS. Same thing. Hormonal regulation. Now see, so which hormone can affect the, previously I told there are two hormones, mainly basically two hormones, one is ADS, another is aldosterone that affect sodium reabsorption. So here aldosterone increases sodium reabsorption, angiotensinogen because it increases aldosterone secretion, so thereby it can increase sodium reabsorption. And ANP, it reduces sodium reabsorbed. Where from ANP is secreted? ANP, what is the full form? Then it is very easy. Where from this way it will be secreted? In the atria. When atria secrecy, when atria is distended too much, then only, that means venous return is more. So I have to reduce the venous return. That's why it is secreted. So why it has increased? Blood volume is increased. Why blood volume? Because lot of fluid is there, lot of sodium is entered. So I have to, its purpose is to reduce. So they are reducing sodium reabsorption in the collecting tubule. You know the function of ADS, and these are already, I think, in your endocrine class, you know it very well. Sodium reabsorption has got clinical significance. If more sodium is reabsorbed, blood or retained in the body, blood pressure will be increased, isn't it? Because it will retain more water, so volume will be more, pressure will be more. Okay, so edema may also be there. Okay, to reduce edema, what we do? We give Lasix, diuretic, so that excess water, ADS cannot, so that ADS cannot act. Anti-ADS drug we will apply so that excess water is eliminated. Okay. Key takeaways. Go through it. These are the main points. What are these? Sodium reabsorption occurs throughout the nephron, mainly in proximal convoluted tubule. And loop of Henle fine-tunes the sodium reabsorption, and collecting duct also allows hormone controlled regulation. Through controlled regulation means aldosterone, through aldosterone, it helps in sodium reabsorption. And sodium reabsorption is energy based. Sodium, no time, already over. I'm sorry I couldn't come, otherwise it could be finished. However, we'll discuss it. There are some more portions to be discussed in our coming competencies. Moreover, bicarbonate secretion, this is essential component of acid-base balance. There also we will discuss this part. How bicarbonate, with the absorption, secretion of bicarbonate ion, you can control our blood pH. So that will be, there are three mechanisms of blood pH regulation. We have to know, means coming class is very important. That is what? It is regarding how urine is concentrated. Okay, so what is the mechanism? There are two mechanisms involved, very important. Try to, before coming to class, try to go through it. Counter current multiplier system, another is counter current exchanger system. With these two systems, we concentrate urine. It will determine whether urine will be concentrated or it will be diluted. So this system this is very important. Common question asked, very common question from day after tomorrow's class. What is this? Counter current mechanism, or the mechanism of concentration, making urine concentrated. Okay, how you can dilute the urine? What is the mechanism? How you can concentrate that is the mechanism. That will involve this. Okay, and after that another part. What is this? Regulation of acid-base balance. And if you want to study, there you can, water reabsorption of the part is there, and also bicarbonate is also there. Action of reabsorption of different these. Bicarbonate reabsorption.